Alright, hello everybody. So, having to kind of go rogue and try and shoot some videos to make up for the lost time we're having in lab. So what I'm going to do today is I'm going to get away from talking about the circuitry and building a circuit and pre-use testing these ventilators, all things that are going to be more suitable for when you guys return to the physical classroom and everything like that. But I'm going to essentially walk you through the next steps of ventilation, and that is really pertains to initiation. So I'm going to show you how to put some initial ventilator settings in. We're going to focus on the Puritan Bennett 980. Luckily, as mentioned before, there's going to be crossover. This is the updated version, kind of the 840, and a lot of similarities. So if you can do it on this, you'll be able to do it on the other ventilator. I'll try and introduce you to one other ventilator through a series of videos and everything like that, but we'll kind of focus on this platform here first, okay? So the thing to remember about ventilator settings is certain places you're going to have a physician that might tell you what's appropriate or what they would like to have the patient placed on after intubation. Now, even if you are at a facility where the physician is telling you to, it's essential that we can understand what is appropriate for that patient, okay? Likewise, you work in an emergency room or you work at other facilities where you have a little bit more freedom, this would be kind of solely up to you, and it's you're coming up with settings, initiating them, and then bouncing them off the physician and letting them know what to sign the orders for. We'll focus a lot more on how to come up with initial ventilator settings a little bit later on here, okay? Right now, our primary focus is going to be learning how to input settings on this ventilator, okay? And then I'm going to walk you through a basic little lab exercise that I would usually have you doing hands-on, okay? But I'm going to kind of walk you through these steps, and we're going to talk about things and really try and lay a little bit of groundwork for a couple of key foundational aspects of ventilation. All right, so I have my circuit on, everything we talked about before we went out on spring break, or this extended spring break. I turned the ventilator on. The thing to remember about the 980 is ensuring, and this is the same for the 840, ensuring when you turn the ventilator on, you do not have any occlusions on the end of the circuit. If you do, it freaks out, thinks you're hooking the patient up without ventilation. It's going to alarm incessantly, one of those high priority alarms that's red at the top. And you're essentially going to have to start over from scratch, okay? So try and keep that in mind. Whenever you do turn it on successfully, it's going to come to this first screen, okay? So from here, we can access a lot of different things. You can see we have the ability to choose a new patient, which is what we're going to focus on here today. Say you had a patient that was on this ventilator in the ICU and they went down to the operating room and you're trying to resume previous settings, you can hit same patient and it's going to pull up the last stuff you had inputted. We'll focus on this once again when we get back into class. SST, or short systems test, it's essentially a pre-use check for the ventilator. So it's going to do some important things. We're going to walk through how to do that on every ventilator, okay, but for right now, it's not our utmost priority and concern. I realize that you're probably having trouble seeing this on the video and everything like that, but it pretty much reiterates all the things I've just said. It will tell you if the SST has been performed, and if so, when was the last time, and it'll tell you if somebody's overridden it, which I've done. It also talks about something called an EST, or Extended Systems Test, and this is something that we don't do on a routine basis here. All right, so first off, you can see, I'm going to hit new patient here in a second, but it shows you how to choose the proper, patient size and everything like that. This does go all the way down to neo. However, if we were going to get out of the adult mode of ventilation, we would actually have to put a neonatal circuit on this thing and then actually go through that short systems test for it to be able to allow us to do so. So that's why it's not giving me the option to change anything. I'm going to go to new patient. It is a touch screen. So when it brings this up, and we kind of talked about this a little bit, it gives you the option of either putting in that patient's predicted body weight, or ideal body weight is what we call it. All right, so if you happen to already know that, you could input that there. However, most people do not know so. So what is really, really nice, you can choose the gender of that patient, okay, and then you can pull up and you can pick a height. So we'll say we're dealing with let's go with a 5'9" man. You can see it's in centimeters. Most people don't know their height in centimeters here in the United States. So we can scroll through and it eventually brings it up to inches down here on the bottom, okay? I'm going to go ahead and we'll hit that to confirm and kind of lock that in place. It's going to bring me to this screen here where it's allowing me to choose a few different things. First off, ventilation type. Would I like to do invasive ventilation or non-invasive ventilation? A majority of times we're going to be focused on invasive. It is useful to realize, though, that all of these modern ventilators are actually quite proficient at being used as non-invasive devices. And we'll focus on that a little bit more as we get into weaning and stuff in the fall and using these machines as standalone, or not standalone, using it as non-invasive ventilation. So for our purposes, we'll be choosing invasive mode, okay? Really, there's only 3 modes of ventilation, all right? So I'm not a liar. We'll talk about what bi-level is, okay? But really, bi-level could be branched back into another one of our core 3 mode types, okay? So in this ventilator, I like the 840 and the 980 series because they actually stick to kind of the tried and true, real textbook kind of classifications of mode names. We have essentially continuous mandatory ventilation, or in their sense, they call it assist control, which is kind of a traditional term. SIMV, so synchronized intermittent mandatory ventilation, okay? IMV and SIMV we'll talk about a little bit more in the lecture component. And we have spontaneous ventilation. Now, so once we choose mode type, and we're going to stick with assist control. This is going to be what you see more often here in our area. And in adult care, this is typically what we're initiating most of our patients with is assist control, or CMV as an initial mode of ventilation. We'll talk about the benefits of that here in a little bit. All right, so one thing I do want to make clear is once we choose the mode, people make the mistake of forgetting that we can choose the control variable that we would like to deliver in every mode of ventilation, okay? So we're going to stick to kind of the tried and true here, but just to show you, we could choose to deliver a set amount of, hang on. Didn't mean to do that here. Let me go back and get our 69-inch patient here. So if you wanted to go ahead and change some of this stuff, okay, we could go ahead, if you hit pressure control, we could choose to actually, instead of guaranteeing a certain size breath every single time, we can control the amount of airway pressure that is attained at that proximal airway. So right there at that patient's ET tube, or just so the Y, we could choose to deliver a consistent and constant amount of pressure to that patient's airway and hopefully, give that pressure and volume delivery down and into the lungs. All right, there's benefits of pressure ventilation, but there's also some negative aspects of pressure ventilation. Typically in St. Louis, you're going to see a lot more of volume-oriented ventilation, at least initially. So PC is pressure control. VC is volume control, okay? So we're actually, instead of locking in a set airway pressure every single time, we can be assured that that patient is going to get a tidal volume that we deem appropriate for that patient. We're going to talk more about how to come up with what is truly, ideal ventilator settings for our patients and everything as we get a little bit further into the class. For our purposes right now, I'll pick some generic numbers as we go through, but it's a very, very important thing that we make sure we give an appropriate size volume, and we'll talk about, what exactly that is for certain patients. All of it, just as we did in the non-invasive realm of things, is based upon how many mils we're given per kilogram of ideal body weight. So for our focus initially, until we really get some stuff down, we're going to be focusing primarily on pressure and volume ventilation as our control variables, okay? I do want to make note that there's something that this ventilator calls VC+, volume control plus. It really is misleading because it is actually a pressure breath, but it has the ability of being able to manipulate the amount of pressure up or down in order to get an appropriate size breath or achieve a target tidal volume that we tell the ventilator to do. Okay, so it's really kind of a hybrid if you want to think about it like that. It's volume targeted pressure control, so it goes up or down on pressure to get us where we need to go. It is quite basic, but once again, not really basic until we really get into the tried and true, the volume control and pressure control here. Okay, so we're going to go ahead. I'm going to go with volume control. You can see spontaneous type is darked out here, grayed out here. And the reason being, the ventilator is not going to allow you to set something that is non-applicable in this current mode of ventilation. Okay, so when you think about what we're doing, and I'm going to bring this ventilator a little bit closer here so you can maybe see a little better. Check my camera work. Okay, so, sorry. It's a little sensitive. Okay, so spontaneous breaths are not available in this mode of ventilation, all right? In assist control, all breaths are mandatory, so it is grayed out, okay? However, if I switch to SIMV, for something we'll talk about later, it does add on spontaneous types, and that's something we'll kind of focus on in a separate lecture, okay? So I'm going to choose assist control. We're going to choose volume as our control variable, so we're going to give a consistent size of a breath every single time. Spontaneous, once again, grayed out. Trigger type. We got V-trig and P-trig, so what we're trying to really establish is what that patient is going to have to do in order to tell the ventilator that it wants to trigger a breath. And remember, even as I go through these ventilator settings here in a second, just because we set a respiratory rate at 10 or 12 or 20 does not mean that is all the patient can get. We always want to allow the patient to be able to trigger a breath, all right, and be able to get that inspiratory assistance whenever they're telling the ventilator that they want to. Any time that we would encounter a situation where we don't want that patient to actively breathe, it would be cruel and inhumane to do so by disabling their ability to trigger breaths. We need to do that through pharmacological sedation and paralysis, and we'll talk about the benefits of that a little bit later on. So you have the option on both. Flow triggers, the V-trig, it is more sensitive or a little bit more responsive. However, I will say with these newer modern ventilators, pressure triggering, if you set that value, -1, -2 centimeters of water, it is quite responsive as well. All right, so we're going to go ahead and go with flow trigger here for right now. Sometimes it's actually too sensitive on this ventilator while I'm doing demos. I might have to adjust that. I'm going to, we'll talk about values for flow trigger here in a second. I'm going to kind of go with a higher flow trigger so it doesn't start to auto trigger on me here. Okay, so what we're going to do, and I'm going to have a handout that goes along with this particular lab, I'm going to start you out with me giving you ventilator settings, okay, you having to be able to figure out how to put them in, and then from there we're going to do a couple little exercises that really help us from a foundational aspect, okay, and understand some core concepts of when we're changing something, what effects that's really taking, on the overall condition of that patient. You can see if I don't do anything quickly, it jumps back to that other screen here, so I'm going to stop talking so much. All right, so down here at our core settings, let me zoom in so you can kind of see this a little bit better. I'm having to be my own cameraman here. One thing that's nice about modern ventilators is it makes it where we don't have to calculate as many things, okay? So once I got my mode type and my control variable, all right, and my trigger type and everything like that, it gives me the ability to set these core settings. So we'll talk about what is a core setting that we're manipulating in volume versus a core setting in pressure ventilation, okay? But essentially all these blue tiles represent things that we have the ability to directly set and control in volume ventilation. Okay, so one cool thing I like about these vents is, once again, if I touch this and I go to turn it, one unique thing that the Puritan Bennett Ventilator series does is it shows us some important things that we would otherwise had to calculate in ventilators of the past, all right, but it does some of that guesswork for us here. So by me changing my respiratory rate, or let's just stick with what I got here for right now, it shows me some important pieces of information. This green piece down here, this little green line, that 0.76 is our set inspiratory time. So in lecture component, we'll get into the fact that we're actually directly fixing inspiratory time and assist control. All breaths are effectively kind of time cycled, okay? So it's important that we actually deliver that breath over an appropriate period of time. We want that breath to get in a timely manner, all right, but we need to keep it down there enough for sufficient gas exchange to take place. And then there becomes whole other aspects of being able to manipulate this as we get a patient that is actively breathing, but that's more of the fall. Okay, so you can see I have a 0.76 inspiratory time. Based upon all these other settings, if I were to go ahead and start it, it shows me actually what my cycle time is. So down here, you can see I got a respiratory rate of 10 set. My cycle time is coming in at 6 seconds. So could you do that math in your head? Absolutely. We use that all the time in class. However, it's going to show you that, all right? Also, then we got the yellow here. So it's showing you that based upon these settings, if I start a ventilation right now, okay, not only is my cycle time 6, my I time is 0.76, it shows me how much time I have available for exhalation. All right, 5.24, we're going to learn how to calculate inspiratory time, and we're going to learn how to calculate inspiratory time to expiratory time ratios and all that. But once again, these ventilators kind of do some of this for us. And then you can see, based upon these proposed settings, it actually breaks that down and turns it into what we call an I to E ratio. So if I were to start ventilation right now, it's going to result in a 1 to 6.89 second I to E. Okay, so we know that most of our patients, it takes twice as long to get the air out as it does get the air in. So at a bare minimum, in most circumstances, we want to maintain at least a 1 to 2 IDE ratio, although we would rather have far more than enough time to exhale rather than not enough. Okay, there's a lot of problems with not having enough time for exhalation, all right, most notably air trapping and auto PEEP, and we'll talk about what that does. But there is no problem with having an extra amount of time for exhalation. It has no negative implications. That is a major positive. So it's important that we think about our patient and what limitations and problems they may have to make sure that we're giving them long enough of a time. All right, even though 1 to 6, sounds like a lot, we might have patients that need a 1 to 10, 1 to 12. Somebody with really, really bad obstructive lung disease, status asthmaticus, COPD exacerbation, something of the sort here. Okay, so let me show you. One of the hallmark things of assist control, regardless of that is pressure or volume, is we are directly fixing inspiratory time. Shouldn't say directly. We're fixing inspiratory time. It's locked, okay? It doesn't change. In this case, all right, we'll talk about what is actually setting the inspiratory time here in a second. All right, but it's important to make sure that we realize that. So if inspiratory time is fixed, as I start making changes to the respiratory rate, you'll see that inspiratory time stays fixed. What happens is my cycle time gets smaller. All right, remember cycle time is the total amount of time for inspiration and expiration to take place. Okay, so if my I time's fixed and my cycle time's getting smaller, we see what takes place. Well, your expiratory time is what gets robbed. Okay, so we got to keep that in mind. We'll do a couple of exercises with that here shortly. So I'm going to go with a respiratory rate of 12. Once again, I'm going to give you this handout and you can follow around. Our settings we're trying to go for are volume assist control, a respiratory rate of 12, a tidal volume of 550 milliliters. Okay, one cool thing I do want to show you here while we're talking about tidal volume is down here in this bottom left-hand part of the screen, it shows me my patient's ideal body weight, and it shows me the mils per kilo I will be giving. This is very useful when you step into a room and you maybe don't have this type of information, fresh on hand or anything like that. It helps us dictate how we're changing ventilation as we get into more of the kind of meaty core concept stuff a little bit later on and everything like that. Most of our patients, we're going to initiate ventilation somewhere in that 6 to 8 mils per kilo range, but we could go down as low as 4 mils per kilo if something wrong were happening. Okay, so respiratory rate of 12, a tidal volume of 550. This next setting is something that on your sheet, it wants you to give 60 liters a minute. Well, let's talk about what this is. So Vmax on this ventilator is something called inspiratory flow, peak flow. All right, it's the speed at which the ventilator is delivering that inspiratory flow to the patient. All right, one notable thing about volume that kind of makes it a bad thing, okay, is that peak inspiratory flow is fixed, meaning not only is that patient going to get a set tidal volume, but the speed at which they're getting that air to achieve that volume delivery is also fixed. So think about the implications of that for a second. Do you take the breath in the same size and move that flow rate, that inspiratory flow? Is it the same every single time? Absolutely not. It can be quite uncomfortable for a lot of our patients as they become active breathing, as they start waking up from sedation and getting a little bit better. And we'll talk more about that. So this is essentially, we're telling the ventilator to kick out 60 liters per minute. All right. We're going to talk about what this is here in a second. We're telling the ventilator to kick out 60 liters a minute until it delivers 550 mils, okay? If I had a professional cameraman here, I'd draw you an equation on the board, but it's something we're going to talk about in lecture quite a bit, and I have it drawn out. But essentially, inspiratory time is the relationship of your set tidal volume, all right? So our goal amount of flow delivery to the patient, which is a volume in essence, so 550, all right? It's tidal volume over your flow rate. Okay, so this is the speed at which we're trying to attain and deliver 550 mils. So this brings us to our first core relationship, okay? By me setting my tidal volume, as I start changing my peak flow, what we see happen is it changes the speed at which I reach my volume target, okay? So think about it. This is us squeezing the bag. If I squeeze it really quickly or I squeeze it really forcefully, the flow coming out is faster, and what happens? I reach my target volume, or I reach my chest rise a lot more quickly. So flow is, in essence, indirectly setting our inspiratory time. Our inspiratory time is going to remain fixed in assist control. Okay, so right now we're going to set it at 60, and you can see that gives us a 1 second inspiratory time. Because of a rate of 12, we have a 5 second cycle time. That gives us 4 seconds remaining for exhalation, and thus an easy IDE ratio of 1 to 4. Hopefully that should be appropriate for our patient. All right, and then once again, just to show you, as we go up on the flow, we're reaching 550 quicker, so our inspiratory time actually drops. Likewise, if I slowed it down, well, I'm going to reach my target tidal volume of 550. It's going to take a little bit longer to do so, and we're going to play with that quite a bit. In volume ventilation, we have the ability to not only set that peak flow rate, but we also have the ability to fine-tune the pattern at which we deliver that flow. And I'm going to zoom back out just a little bit here. There we go. So this goes by a bunch of different words: ramp, decelerating flow waveform, exponential decay, but essentially it's dictating how we are going to deliver that flow to the patient. All right. Older ventilators, you didn't have the ability to do this in volume ventilation. Modern ones we do. And what we typically find us using on a majority of our patients in volume ventilation is this ramp or descending, decelerating flow pattern. And what that means is you are delivering 60, but just like when you think about breathing, when's your flow the highest? Typically at the beginning of the breath for most of our patients. Okay, sometimes that changes a little bit. But what this is doing is it's reaching 60 right at the beginning of that breath, but then just like normal, as that patient's lungs are filling up, it slows down the flow rate. So we're really just reaching that peak flow right there at the beginning, and then it tapers that flow off as the patient's lungs fill up. Okay, why is this important? Well, there's other options. We can do a constant or a square. In this case, we're delivering 60 liters a minute at the beginning, all the way to 60 liters a minute at the end. So I know you can't see me right now, but think about that. If you were breathing at the same flow rate at the beginning of the breath as you were at the end, not very comfortable, okay? And consequently, this does play a role on our inspiratory time. 99.9% of the time, you should be running a descending or this ramp flow pattern in volume ventilation. We'll talk about a few benefits, possible benefits of doing it without, or using a square or some of these other waveforms. Majority of the time, you're going to find that this is completely appropriate. So, TPL. TPL is time for plateau, or a pause time. We don't routinely set a pause time. What that means is you give your 550 mils and then hold it in there for a certain amount of seconds every breath. You can use that as a way of being able to measure something. You could use it as a way technically to improve somebody's oxygenation. However, it's quite uncomfortable, and it's not typically something we routinely do. Although if you wanted to, you'd have the ability to do so. So these are kind of what I consider our core controls for how we're going to ventilate this patient. Okay, so this is the core aspects of volume delivery, or the core aspects of inspiration. Okay, over here it's kind of got things segregated. All right, let's talk about what we have. This is going to be where you change your things that affect oxygenation, and when you think about oxygenation, that's going to be our baseline pressure. So we learned a lot about baseline pressure in the non-invasive segments. Remember, instead of calling it EPAP or CPAP, on invasive ventilation we're calling it PEEP. Okay, so PEEP, positive end expiratory pressure, is what's responsible for keeping the lung opened up, and it's going to drive oxygenation. It's going to prevent atelectasis. It's going to give us a lot of beneficial aspects. Once we put a breathing tube in a patient, all right, we're losing some of that normal FRC just for the fact that they're not actively breathing a lot of times. They have a tube in when they're exhaling. And them not actively participating in diaphragmatic contraction initially, or we can have some atelectasis. So every one of our patients should typically be started out on a PEEP of 5. Are there some contraindications that, most notably, an untreated tension pneumo, you want to turn your PEEP down, so an emergency room setting, that can be useful, but a majority of the time a PEEP of 5 is going to be totally fine. I call this maintaining a normal physiologic PEEP, okay? As we start getting up to, 10, 12, 22, crazy high levels of PEEP, I call that therapeutic PEEP, all right? Or the ability of manipulating that baseline to really drive oxygenation. So we're using it to try and improve something or, stabilize the air sac, something along those lines. most of our patients, especially here in St. Louis, are going to get a PEEP of 5. All right, flow trigger, I'll be honest, typically on an adult patient, anywhere 2 to 5 liters a minute is appropriate. I find the Puritan Bennett ventilators to be very, very sensitive. Sometimes 2, you'll see that thing auto-trigger quite a bit. I'm going to run it on 5 liters a minute here for right now, but don't be surprised if you see it a little bit lower. If this thing becomes so sensitive as I'm playing with things, I might change it to pressure trigger, okay? But I typically wouldn't have to do that clinically. So to touch, and I should have told you this, to make any manipulations, if you touch, you can turn the little wheel here, and you can lock it in place by double tap or tapping the screen again. FiO2, so we're going to talk about how to, what to implement as far as, your patient's FiO2 and everything like that. Sometimes we know what they've been on and what they're doing okay on. Sometimes we have no idea. If you don't know, there's typically no problems with starting somebody on 100% as long as we have the intention of weaning them down to a safer value as quickly as possible. Okay, sometimes you have baseline information. So somebody's failing BiPAP, but they're oxygenating okay and they're on 40%. We can carry over. Okay, very rarely we start somebody on 21% in the adult population or anything. I'm going to do so here today because we don't have a real patient. And actually, never mind, on our little handout here, we got an FiO2 of 60. So we'll practice setting that, but I'm going to have to disable the oxygen analyzer on this, which you would not do in clinical practice. So as of right now, our core settings are in. We are going to give 12 breaths a minute, 12 mandatory breaths. Those breaths are going to be 550 mils. All right, that flow rate that we're reaching that 550, the peak flow is going to be 60. We're delivering that in a decelerating fashion, or this ramp flow weight pattern. Okay, it's going to result in a 1 second I time, which is normal. Most of our patients, we got a 0.8 to 1 second I time. Sometimes we'll go a little bit lower. Sometimes we'll go a little bit longer. Okay, should have a sufficient amount of expiratory time here. 4 seconds, 1 to 4 ID ratio. No built-in pause time. Should my patient want to breathe faster than 12 breaths per minute, they absolutely can do so. All they have to do is pull 5 liters a minute of inspiratory flow. So that diaphragm pulls down, makes that little flow change at the ventilator Y. Ventilator senses that, and it's going to kick in a breath. Now, one notable thing that we'll get to with assist control is regardless of who triggers the breath. So if the ventilator does a time triggered breath because my timer goes off and it kicks in and gives a time triggered breath to this patient, it's going to be 550 mils at 60 liters a minute. All right, it's going to take 1 second to do so. If my patient decides to trigger a breath, all right, and they pull in that 5 liters, the ventilator kicks in, all it's doing, they're still going to get the same exact breath. It's going to be 550 mils. It's going to be 60 liters a minute of flow. To deliver that 550, regardless if that patient needs that much or if they need more, okay? And it's going to take 1 second to do so. So the hallmark thing about assist control, CMV, whatever you want to call it, is that it doesn't matter who starts the breath, the same result occurs, okay? So all this patient has to do is start that initial little inspiratory effort, the machine's going to kick in, and it's going to give them a mandatory breath. So, dang it. I've never had it on that startup screen for that long before, so that should not be a problem clinically. Of course, it didn't save any of my settings, so I'm going to quickly run through all this stuff here. So 12, 550, peak flow of 60. We'll do a flow trigger of 5, 60%. And let's talk a little bit more. Okay, so we said that the patient is going to trigger a breath and the same result occurs, and that's a hallmark thing of assist control ventilation. There's whenever the patient exhales, so that breath is cycled off after that 1 second, they've delivered that 550 mils, they're going to go back down to our baseline of PEEP of 5. The pressure in their lungs is going to be great because of the work that we've done to push that breath in. Okay, the elastic recoil of the lungs should make them quickly, hopefully exhale down to that baseline pressure of 5. And then the timer resets and we're just waiting. Okay, remember, by us setting this respiratory rate, we were setting the longest period of time, in essence, that patient could go without triggering a breath. Every time they trigger, it resets that timer. So they may never get a time trigger breath. It could be all patient triggered if they're breathing faster than what that set cycle time is, or that set rate. Let's talk about one last thing here. So one thing that I like is when ventilators give me the option of setting this, okay? And what this is, and it's called something different on every ventilator, it's actually me setting my peak pressure alarm, okay? So high pressure alarm, peak pressure alarm, inspiratory pressure limit. whatever you'd like to call it. And you might ask yourself, well, why is that important? I don't know what they're going to be registering when I hook them up. And that in itself is exactly why you want to be able to set this, all right, when you're initiating ventilation. Keep in mind, we are trying to deliver a certain tidal